Now let's talk about a certain type of plasma cell disorder, which is described by the term Waldenstrom's macroglobulinemia. If you break down the term Waldenstrom's macroglobulinemia, it gives us a good indication. Waldenstrom is the name of the scientist which described this disorder for the first time in 1948. Macroglobulinemia. Emia means present in the blood. Globulinemia means globulins, which are generally, in this term, we can say the gamma globulins or the antibodies. And macro means big. So the presence of big antibodies into the blood, the excess of the big antibodies is termed as macroglobulinemia. The biggest antibody in terms of size and avidity and has a pentamer shape, it's the IgM antibody. So basically in Waldenstrom's macroglobulinemia, you can simply say that there is an excess of the IgM antibody in the blood. This disorder, Waldenstrom's macroglobulinemia, it basically shares some common features with the plasma cell disorders, but it has its own specific features. In contrast to the multiple myeloma, there is no sclerotic lesions of the bones, sclerotic lesion, and there is no hypercalcemia. These are the two things that signify an multiple myeloma disorder, but these two are absent in macroglobulinemia. The major features of this disorder are the hyperviscosity. Because of an increased size of this antibody, it leads to a very viscous plasma, and as the quantity of the antibody, the IgM, keeps going on increasing, the plasma viscosity starts to increase even more. So this leads to difficulty in the flow of the blood, which can lead to thrombosis. It can present in various types of hyperviscosity presentations in the neurologic symptom or the eye symptoms or the renal pathologies. We're going to talk about these signs and symptoms in the coming slides. Apart from it, some things which are not seen in the multiple myeloma, like we have lymphoid adenopathy in this disorder. We also have splenomegaly. So this shows that apart from the plasma cells, this disorder also affects the lymphoid lineages outside of the bone marrow. It can lead to lymphadenopathy. It can lead to various types of splenomegaly. So let's look at the major clinical features present in this disorder. The patient might present to you with dizziness. The patients are generally older, as similar to the multiple myeloma. It has, again, presents around 60 to 70 years of age, the median age of presentation. It also affects males commonly as compared to females, similar to the multiple myeloma. The dizziness, a headache, and the other types of neurological features may be because of hyperviscosity. Because of a viscous blood moving through the capillaries, the brain is unable to get enough supply. This leads to dizziness, vertigo, headaches. The severe fatigue is in partly because of the anemia. It has a similar normocytic normochromic anemia, with the MCV being between 80 to 100 in normal ranges. And this fatigue is because of that, generally because of anemia. So also because of the hyperviscosity features, we might have cyanotic skins or the blue discoloration of the skin appendages. Specifically, in certain types of Waldenstrom macroglobulinemia, we also have different cryoglobulins. And IgM, as you know, that it precipitates at low temperature. So it can present in varying forms in the form of a Raynaud phenomena or the Raynaud's disease, in which during the cold temperatures, the tips of the digits, they get cyanosed because of the impaired flow of the blood. So Raynaud's phenomena or the Raynaud's presentation is also one of the presentations of the Waldenstrom macroglobulinemia in winters, and it is because of certain types of cryoglobulins, which are also an IgM, which precipitate at low temperatures. Along with that, because of an increase in these IgM overproduction, they interfere with the working of the platelets. They lead to impairment of the clotting factors and also impairment of the clumping of the platelets together to form a clot. And this can lead to easy bruising. It might have a similar presentation to someone having a platelet pathology, but the underlying mechanism is different from a platelet disorder. These are the major initial presentations. Along with that, because of this easy bruising, we can have gum bleeding. The flank pain might be because of organomegaly. If we have an enlarged spleen or hepatomegaly, it can also present with flank pain, or it can, if the blood supply is occluded to the renal system, the kidneys, it can also present with acute renal failure and also a flank pain with a flank mass. Nose bleeding or epistasis is also because of coagulation factors abnormalities. The coagulation factors clumping is basically because of an increase in the IgM antibodies or the various types of globulins. They interfere with the coagulation factors production and with their interaction with the endothelium. So this leads to problems with bleeding either from the platelets or from the coagulation factor. So we have a superficial bleed as well with the help of which is signified by an epistasis, and we have deep bleeding as well, which can be shown by the heme arthrosis, for example. Certain types of varied skin presentation, skin rash might be present in some patients. Swelling of the glands because it also affects the lymphoid lineage, and also because this is a neoplastic lesion, the patient will have weight loss because of all of this overproduction of these cells. All of these signs and symptoms need not be present in one patient. Some patient will have just the swelling of the gland, some will present with just a splenomegaly, the other might present with just a small bleed. So it basically becomes a very difficult disorder to diagnose, and to have a complete confidence in our diagnosis, we have to do the various investigations. We have to do the electrophoresis, as we talked about in the previous slides. We have to then confirm them with the help of a plasma biopsy of the bone marrow. The biopsy of the bone marrow will show greater than 10% of the plasma in the lymphoid cells in the bone marrow. So that basically signifies that we have a Waldenstrom macroglobulinemia. And then when we do an immunohistochemistry of the bone marrow, we will see that the antibodies or the plasma cells leading to the production of the antibodies, the excess ones are the IgM. In contrary to the multiple myeloma, which generally has an increase in IgG or IgA types of antibodies. So these are the important features that differentiate a Waldenstrom macroglobulinemia for the other plasma cell disorders, specifically the multiple myeloma, which is the major disorder of this group. Now let's look at how can we treat Waldenstrom macroglobulinemia. The major options which we have, the major symptoms, the major troublesome symptoms which we have are the hyperviscosity symptoms. So to counter the hyperviscosity symptoms, the simple thing to do is plasmapheresis, which with small intervals of time we remove small plasma with incision. This leads to removal of that viscous blood, and it leads to improvement in the symptoms. It leads to improvement in the bleeding symptoms. It leads to improvement in the clotting profile and the overall presentation of the patient. Apart from it, to complement that, and if this plasmapheresis does not work, we have certain drugs, like certain newer drugs, which are basically the immunomodulators, like the bortezomib, which is a monoclonal antibody. We have a newer drug called bendamustine, and certain types of anti-cancer drugs, because this is in part a monoclonal malignancy of the plasma cells. So we have certain cytotoxic anti-cancer drugs like the fludarabine. It's a 4-week course which is generally given to the patient. Apart from that, we can also use cladribine. This is also a newer drug. So all of these drugs are tried in various combinations. They all have their own cytotoxic profile, their own side effects, but we look at the risk and the benefit ratio and what helps the one patient. It's not necessary. For example, if one patient responds to fludarabine, the other patient might not respond. So we have to try on different drugs to improve the quality of life within the patient. And along with that, when the drugs stop working, we can do plasmapheresis at various intervals in this patient to improve the symptoms. So there is no definitive treatment. These all drugs are symptomatic, and they improve the one symptom or the another, leading to an improvement in the overall profile of the patient.